mention that this is a problem, the problem of high blood pressure has a global prevalence, and you can see that the number of people in all countries, and particularly those showing red, have the highest number of hypertensives, is large and growing. Next slide. Growing over the last few years at a phenomenal rate, both in European and the affluent nations, but much more so in the Southeast Asia and Western Pacific region. And therefore, this 30-year increase, as shown by this graph, tells you that we are facing as bad a problem as diabetes as we are of hypertension. And therefore, it should be tackled with the same intensity and war footing that has now been given quite correctly to diabetes mellitus. Next slide. So the global prevalence of chronic kidney disease, which has become a major problem for countries because it's the one illness that people can be kept alive with no kidney function. So I can remove both kidneys, or they be completely damaged and zero function, and keep them alive for years with dialysis and transplant. But that costs, and the cost burden is so heavy that countries like America also now feeling the pressure on their health resources, and poorer countries with still a lot of infection have to first pay attention to those diseases which are easily curable and not worry about the global health issues of non-communicable illnesses, which are taking a heavy toll of life and cost. And because most countries are now giving free dialysis, and that is a huge economic burden. So the main thing is to try your best to prevent these. The prevention is better than cure. Next slide. Next slide. Yeah. So this shows that there is now an increasing death rate, and from a rank of 19th in 2012, we have come to a point where the death rate is in 2017 is 12th in rank for due to hypertension, and by 2040 we will be looking at a large burden of CKD causing death, and maybe the fifth in the rate of increase, with a 41% increase from kidney disease between the last 35 to 40 years. This is a large burden, socio-economic and emotional and social and ill health causing cause for our patients. So we have to prevent. Next slide. So if we look at any disease, particularly look at the non-communicable CKD, the major risk factors, besides others, are the diabetes and the hypertension. Between the two of them, they constitute almost 40%. And this cycle that we see from endothelial dysfunction in the kidney to microalbuminuria, macroalbuminuria, nephrotic proteinuria, and end-stage renal disease, the treatment must begin early, at the very point where the disease is at a stage 0, or what are the unobservable clinical, non-clinical changes. Look at it at the time of micro changes, which are not easily detectable unless we go fishing for them and hunt for them. And therefore, next slide, please. These, therefore, are the organs that get damaged by blood pressure: the brain, the eyes, the heart, the kidneys, and the peripheral arteries. And in the heart, I would say that the heart is king. And therefore, not only the arteries causing coronary artery disease, and the muscles of the heart causing left ventricular hypertrophy, going on thereafter to dilatation, and then asymmetric dilatation, and then valvular leakages, and thereafter severe congestive heart failure. So these are the organs that need to be looked at carefully. And today I will keep the heart a little aside, although it will always remain in my priority that heart is king. So the kidneys is what I'm going to talk about. How do I prevent kidney damage? Because I'm at base a nephrologist, but I teach all my students that whatever you learn in nephrology, the heart is still king. So whenever there is a choice between heart and kidneys, remember the heart cannot be replaced. I can remove both kidneys and keep a person on dialysis. I can't do that with the heart. But today we will talk about kidney damage from blood pressure. Next slide. So we must start at stage 1. That is when the healthy, or stage 0, before the ill health of the kidney starts, and go down over stage 1, 2, 3, 4, until stage 5, which is kidney failure. In fact, the word failure is now no longer kept for the first 4 stages. Stage 5 is where failure takes place. And this is what we have to prevent as early as possible in the antihypertensive therapy. Next slide. So these are the new classification of CKD. In the past, you see here on the left side of this heat map, the GFR charts and the stages which you may have learned 20 years ago. And from these stages, GFR that we measure, and now the eGFR by various equations, a person with more than 90 has normal or high GFR. You see that with kidney disease and diabetes, you can see hyperfiltration. And then slowly it comes down to 2, 3, 3A, 3B, 4, and 5. But what has been added on in the last few years is the 3 stages of albuminuria, because until now, a lot of emphasis was on GFR. But today there is equal emphasis on proteinuria. So if there is a little proteinuria, less than 30 milligrams per day, then that is called A1. Then this is albuminuria, not proteinuria, but as a reflection of proteinuria. So A1 is less than 31, A2 is 30 through 300, and more than 300 is gross proteinuria. And this has come because in stages 1 and 2, the ordinary urinary test of the dipstick will not pick up A1 and A2. And you need microalbuminuria to pick up that. Once it's A3, it is picked up in the simple laboratory urine examination. And this shows you the heat map. It shows you that the combination of the proteinuria or the albuminuria, high albuminuria, and the low GFR is in the red. That is where the patient is going to have progressive, non-returnable disease and lead to dialysis and transplant. And therefore, we must reach the patient before that in the green, preferably most, otherwise in the yellow or in the orange stages. Next slide. So the most important thing, if you see in the world statistics, even the best countries which have the best hypertension programs like Canada and Europe and Italy, the most important thing that has been emphasized that if we are to reach the blood pressure at target, you must get it correct. You must correctly read and decide what the actual blood pressure is. And therefore, this cartoon tells you that it's easier said than done. The simple thing that we ask of office pressure, next slide, is to check it correctly. Next slide, please. Yes. So you see here our KDIGO, which is the universally accepted guideline maker of nephrology, tells us how this should be done, whether it's done at home or it's done in the office. And it is very important to understand that there are times when people have white coat hypertension, which is just the presence of the hospital or the environment of the doctor. But the most important, there is masked hypertension. And in CKD, that is the most prevalent amongst all hypertensives. The CKD hypertensive will have very severe undetected hypertension, particularly either at the daytime, which will be detected by home blood pressure, but more important at night, which will be detected by ambulatory blood pressure. And that is masked hypertension has 3 times more evidence, more incidence of CV events and 4 times more incidence in CKD. So in ESRD, that is CKD stage 5. Next slide, please. So the correct measurement is most important. But at the moment, I will not deviate into how to measure, except that you have to learn to measure correctly. Now, having said that, there are effectively two types of hypertension. Those which are primary or essential. Essential is a bad word. There's nothing essential about the hypertension. It's genetic. It is an acknowledgement of our ignorance that 95% of the time we cannot tell why this hypertension is taking place. The word essential was used in America many years ago when we didn't know, and we actually thought that it is essential for the kidneys to function and the heart to function and the body to function, because at lower pressure the body doesn't function. This is a bad word, but it continues, so we call it primary hypertension. And there are clear-cut conditions where it is secondary hypertension, secondary to diabetes, glomerulonephritis, interstitial nephritis, kidney stones, and heredofamilial. Next slide, please. This is our CKD registry, and if you will see, the first primary causes of hypertension causing CKD include diabetic in 27% of our patients, and hypertension itself causes 15% to have CKD. So this is really a very paradoxical thing.